In 2022, the United States spent more than 17% of GDP on healthcare. Now, that's a significantly higher number than the 9.9% of GDP our peer high-income countries spent on healthcare on average. You might be thinking, well, we must have better health services or healthcare outcomes, but that's not actually the case. Higher healthcare spending in the United States has not led to an abundance of services or to improved outcomes for patients. So what's happening? How can we get more out of this substantial investment? I'm joined today by Elena Marks and Charles Mathias, two experts from our Center for Health and Biosciences who recently co-authored a report on this topic to explore the questions. Elena is our Senior Fellow in Health Policy. Her work focuses on achieving health equity in the United States and health system reform. She's also the co-founder of the Texas Consortium for the Non-Medical Drivers of Health, which is based at the Baker Institute and which is directed by Charles, who joined us this year following his time at UT Health San Antonio as a professor of psychiatry. Together, we'll discuss healthcare spending in Texas and how we could invest more smartly for better health outcomes at both the state and federal levels. I'm David Satterfield, Director of Rice University's Baker Institute for Public Policy in Houston, Texas, and this is Baker Briefing. Elena, Charles, thank you for joining me today. Let's start with the numbers. Elena, when we talk about having worse health outcomes than our high-end peer countries, what are those outcomes we're talking about? What do they look like here in the United States as a whole, and specifically in Texas?
Well, one of the most common indicators we use is life expectancy, meaning how long people live. When we compare the U.S. to other high-income developed countries, we see that life expectancy in the U.S. is the lowest among 19 OECD countries. And what's really disheartening is that while other countries continue to make gains, we're actually losing ground and falling farther behind. We're also lagging in maternal and infant deaths and in obesity. And obesity is an underlying cause of many of the chronic conditions that shorten people's lives. And Texas's health statistics are among the worst in the U.S. We're usually in the bottom 5 to 10 states for things like deaths from preventable and treatable diseases and childhood and adult obesity. So the U.S. is doing worse than peer countries, and Texas is doing among the worst among U.S. states.
Now, Elena and Charles, you as well, if you wish to join in, let's break down what you just said. Texas, the United States, for all of our expenditures, are not only having lower outcomes than peer countries, but those outcomes are deteriorating. Is this due to medical factors, delivery of services factors, or non-medical health issues, lifestyle, diet, etc.?
Well, it's really a complicated question. Our national health expenditures that come from government, business, from families, over $4.5 trillion in 2022. 1/3 of that money is going to hospitals. And that's why we see so much attention paid by policymakers and advocates to reducing those costs. About 20% goes to other kinds of providers like doctors and clinics. And while we talk a lot about rising prescription drug costs, and they are high and they're growing, they only account for about 10% of the total spend. And so the problem that we see is that the U.S. is investing lots of money way after the fact, after people are really sick, and we have incentives in a system that incent organizations, particularly hospitals, to treat people with good insurance once they're really sick. We just don't have the same incentives for prevention and upstream solutions.
What should policymakers do to address what you've just described? Should we increase the amount spent in an effort to improve quality of care? Should we prioritize reductions in spending, since we apparently are not getting value for money?
The truth is we're not getting value for money, and investing more money in medical care is definitely not the answer. If we keep doing that, our outcomes aren't going to get any better. What we'd like to see is that a larger share of the $4.5 trillion gets redirected toward non-medical factors that are known to be able to improve health outcomes. And in some cases, they actually reduce medical costs. We have more tools available to us than just medical care. And in the US, we have conflated medical care with health, and we think that the more medical care you get, the healthier we'll be. We need to use more of those non-medical tools. And my favorite example of this, because it's really easy to explain, is in the case of asthma. The medical system is good at diagnosing asthma, and it can prescribe medicines to keep asthma in check and to respond when people have asthma attacks. But what if what's causing the asthma attacks are allergens, contaminants in the patient's home? What if they're caused by mold or pest infestation? Medicine can't address that, but there are programs that visit patients' homes and they look at what's going on in there and they actually remediate efforts. They change out carpets, they spray for pests, and then they can actually prevent asthma attacks. And the cost of doing these home remediations is often less than the cost of one emergency room visit for an asthma attack. We need to spend more of our health dollars on things that are upstream, non-clinical, and actually prevent the need for people to interact with the medical system.
And would you include diet and healthy eating as part of that?
Absolutely. I mean, there is a long list of non-medical drivers of health, as we call them. The first one that everyone looks to is food and nutrition. The causal connection between inadequate diets and inappropriate diets and chronic diseases like diabetes, like hypertension, like chronic kidney disease is well documented in the medical literature. What the medical system does, though, is prescribe medicine and other clinical interventions for those conditions. And what we need to do is take some of those dollars and move them to providing access to healthy and nutritious foods so that people don't get those conditions in the first place. Or if they get them, because some people will naturally develop them, that they are able to ameliorate the impact and stop the progression of chronic diseases by keeping them in check with healthier foods.
Charles, given all of this, that the resolution here is not just more money translating into better outcomes, how do we actually practically improve the quality of services, if not by just adding money into the system?
It's not about spending more money, but using it wisely. We often get caught up in cost, which is important if we were getting value out of that price. If we had the best healthcare in the world, we wouldn't be so focused on cost because it would seem worth it. So this conversation needs to be about value, which is the quality of health outcomes divided by the cost that we spend on them. Since healthcare prices are tough to change, we can improve value by boosting health outcomes. That's where addressing non-medical needs comes in. It can improve health more effectively than medical interventions alone when it comes to managing the population's health.
And could you talk to our audience about what those drivers, those non-medical drivers are? Elena mentioned diet, healthy eating as a critical and long-standing such non-medical factor. What else is out there?
Non-medical drivers are the conditions where we're born, live, go to school, work, socialize, and age. The conditions of those can really set us up on a path of health or put us at risk for serious chronic illness. So things like access to fruits and vegetables and sufficient proteins, or having a house that's free of mold, or not living in a home with domestic violence, or having a way to get to medical appointments through and work through transportation. All these factors have a bigger impact on health and lifespan of medical care alone. The county health rankings kind of are one way we use to characterize the health of a community, and those identify about 20% of health is coming from the medical interventions we have, whereas 40% comes from socioeconomic factors like employment, education, and social support. So focusing on those larger drivers has a bigger chance at influencing the health of our population.
Let's talk about Texas specifically. How has Texas addressed in the past these issues, these problems, and its own low standing? How is it managing non-medical services or preventive non-medical services that address the drivers of what become medical conditions?
Texas has a long history of covering non-medical services, especially for specific health conditions. Since the early 60s, the state has been supporting services like housing, family support, and now even employment and peer support for people living with serious mental illness. This approach helps ease the burden on state hospitals by promoting community living. In the 1970s, the state started funding temporary housing support and legal services for women and children experiencing family violence. This program now has expanded to include employment and educational supports. So the idea that the state policies addressing non-medical needs is not new. What's new is the data showing that meeting these non-medical needs can improve health outcomes and make healthcare dollars go further on a wider range of conditions and populations that was previously recognized.
Charles, in your experience, in your work, why is it that Texas then, if it has this extended history of providing care, of providing financing for these services, why are the outcomes in Texas so poor compared to other states? What's unique here?
Well, it's just not a tool that we've taken full advantage of through the healthcare system. A lot of these services traditionally are delivered by community-based organizations, which do a wonderful job and are of high value to our citizens. The challenge is those systems aren't always funded in a way that connects them with the health system. So we're closing the loop between identified health need, the funding that goes into address that need, and the services that address non-medical needs.
And are other states conversely doing better than Texas on all of these issues that you just named?
Elena, I'm going to kick that one to you.
Well, most states have better health outcomes than Texas. What other states are doing and what we hope Texas can learn from them, and this was really the gist of our report, is that there are lots of opportunities. And we provided examples, more than 24 examples from all sorts of states, red states, blue states, large states, small states, Medicaid expansion states, non-Medicaid expansion states, of different ways that the states are using existing authorities, particularly within the Medicaid program, to use these other non-medical services to support their patient populations. And they're great examples from across the country, including medically tailored meals, housing supports, asthma remediation. As Charles said, we've done a little of this in Texas, but we need to really ramp it up, and it needs to become the norm, not an aberration.
Elena, I've got to follow up on that by asking a question many of our listeners may well have. In your statistical research, when Texas is compared to other states, you are comparing apples and apples. That is, you're looking at similar patterns of socioeconomic, demographics, identity, how other states deal with the same kinds of communities that Texas deals with, correct?
Well, when we're looking at the Medicaid program, we're looking at some non-expansion states. You really are talking about the exact same populations because the requirements or the eligibility are about the same. When we look at overall health statistics, we're looking at the population as a whole. And so when we say things like the maternal mortality rate is higher in Texas than in other states, that considers all women, not particular women or women covered by a particular program or not.
And let's talk about Medicaid expansion and the handful of states that have not expanded Medicaid, including Texas. In that class, in that specific group of non-expansion, Texas still ranks poorly?
No, Texas is more middling with a lot of those states. A lot of the states who haven't expanded Medicaid. So first of all, if you expand Medicaid and you give more people access to the healthcare system, their health does generally improve. I mean, Medicaid is a really good thing. Medical care is a really good thing. Although we're talking about how important these non-medical factors are, access to quality medical care is essential. I don't want to say, oh, forget about medical care. We'll just do all of this non-medical stuff. That's not the case. So once you get into the Medicaid program, you're in the system. And so you do have a better chance of becoming healthier. Also, when you're in the Medicaid program, and you have an expanded population, and you're in states that have embraced some of these flexibilities to do more in Medicaid than just provide medical services, that's where I think you start to see the differences in why their overall population health statistics may be better than Texas. They're covering more people and they're using more tools in the toolbox than just medical services for that enlarged population.
Which is a critical point, that Medicaid expansion is not just expanding classic medical services. It extends to the kinds of things you and Charles are focused on here in terms of non-medical drivers of healthcare needs.
Yes, to the extent the state embraces them. And so we see a difference across states about who is going to embrace the opportunities presented to them. And the purpose of our report was to be able to show Texans and lawmakers and advocates here are all the different ways other states are doing this. Texas can follow this same roadmap within Medicaid. It would be better if we had expanded Medicaid because then more people would be able to take advantage of it. But there are two factors. One is, are you on Medicaid? And number two, is your state willing to embrace these, I would say, more upstream and prevention-oriented ways of dealing with health issues? And Texas has shown a little bit of interest in doing that, and we're really excited about that. What we hope this report will do is provide the basis for them to do even more, understanding how big the opportunities can be.
Charles, how, in a structural sense, does Texas determine the options available to it when it comes to cost efficiency and quality of care? How does this work?
In our most recent report on enhancing Texas's healthcare investment, we found three key areas to focus on. First, build on what's already working. Health and Human Services already has an action plan to address non-medical drivers like food insecurity. Next phase, that plan could include medically tailored meals for patients with complex and costly medical conditions, which other states have found to be valuable. Second, the state has priority populations, like we want to take care of our veterans. Veterans often have worse health than non-veterans. By addressing their nutritional and housing needs, we can help them get the most out of their medical care. Third, focus on common yet costly health conditions that have been shown to respond to non-medical services. Take, for example, kidney disease. Our state plan and task force focus on late stages of that disease when people are on dialysis and need a kidney transplant. The studies here in Texas have already shown if we provide proper nutrition earlier in the disease, we can reverse the condition and prevent it from reaching the later stages of the disease, which is both very costly and significantly reduces quality of life.
Charles, Elena, a lot of attention has been paid to the growing discrepancy between availability of healthcare, particularly hospital, but not just hospital healthcare, in urban areas of Texas and in rural areas. When you look at non-medical drivers of health conditions, how serious is the divide between rural Texas and urban Texas?
Well, the health outcomes of rural Texans are typically not as good as urban Texans. Some of that is because they don't have access to the same amount or quality of medical care, but they also often have fewer opportunities to have non-medical services. One of the things we've discovered as we've been doing this work statewide is that in the urban areas, when a hospital or a healthcare provider wants to connect their patients to non-medical services, there is a bunch of options for them. In rural areas, you simply don't have as many of the social service organizations, food banks, housing organizations, transportation organizations. And so the work is just harder to do in rural areas.
For both of you, a patient comes in now with a clinical diagnosable medical condition to an emergency room. She is treated for that condition. Is there then a structure to refer them to the kind of care systems that can address the underlying cause of the problem, that doesn't bring them back to the emergency room again and again and again? Or is that not functional?
That's a fantastic question. What has been happening over the last few years is that the regulatory and accrediting bodies that govern hospitals and other kinds of healthcare providers have been requiring that hospitals and other kinds of providers screen their patients for non-medical needs. It's usually a handful of questions that are asked. They usually have to do with food insecurity, housing insecurity, transportation, interpersonal violence, things like that. And they are supposed to come up with a plan to refer that patient or get their patient's needs met. This is just rolling out now. The screening is becoming increasingly prevalent. The next step is, what is it that these healthcare organizations are going to do to get the patients what they need? And of course, the bigger question is, who's going to pay for that? And so that's why our work is focused on, we ought to be using healthcare dollars for this. That would be a better use of healthcare dollars than paying for them to come back to the emergency room.
And now, what about the political landscape in Texas, Elena? Is this an issue both sides of the aisle in the legislature want to address, are prepared to address, and assign a priority to?
So far, particularly at the federal level, the investment in non-medical services with healthcare dollars has been bipartisan. There was movement forward during the Trump administration and even more movement forward in the Biden administration. The way that trickles down to Texas is largely what Texas is willing to do with its Medicaid population. Texas has primarily been concerned, as a very conservative state that doesn't want to expand Medicaid, with keeping Medicaid costs down. And what we're trying to do through our work and the way we're framing our work is saying, another way to look at this question is, why don't we have better health outcomes for the dollars we are spending? Why don't we do something different with those dollars? And in the last legislative session, there was a bill passed that explicitly recognized the importance of non-medical drivers, and it put into place a requirement for all pregnant women who are on the Medicaid program, which is about 200,000 a year, that each of them be screened for a certain set of non-medical needs, and that the health plans that are administering the program have to actually navigate them to those services. And so it's not that it's paying for the food or the housing, but part of the problem with getting access to food and housing programs is knowing where they are and having the time and the wherewithal to do it. And now that the state is requiring that these women receive case management, the likelihood that they're going to get connected to a source for food or transportation or housing or whatever other need has been identified is much greater than if all you did was hand them a piece of paper and say, good luck, here's a list of food pantries.
Elena, final question. Your work is focused, the paper that you and Charles have done, on how to use existing healthcare dollars for better outcomes rather than increasing, whether at federal level or state level, monies available. But I will ask a quantifiable question. In states that have expanded Medicaid, the existing experience, are state costs in fact increased or not?
Well, there is a lot of data over the last decade since we've had Medicaid expansion that looks at what happens to state budgets and to state economies as Medicaid expansion rolls out. So do the costs of the Medicaid program increase? The answer is yes. But the impact of that increase ends up benefiting the state in a number of different ways. One, it increases the economy because, frankly, providing medical services is part of the economy and a booming part in many states, and especially in Houston. Second, you see increased productivity because more people are less ill and better able to work. And you can see even at the local governmental level that there are benefits to the taxing structures at the local level and to the economy at the state level, including the state budget, that offsets the additional costs. So from an economic standpoint, Medicaid expansion is a benefit to states, and that is virtually undisputed after many, many studies over several years now of Medicaid expansion.
It is then a political issue rather than a budget issue.
Yes, absolutely.
Charles, Elena, thank you. And thank you all for listening. For more on the topic just discussed, you can read the paper we referred to from Elena Marks and Charles Mathias, and a link is available in the show notes. Baker Briefing is brought to you by the Baker Institute for Public Policy, which provides meaningful, nonpartisan policy analysis on the most critical challenges facing the United States, Texas, and the world. This episode was produced by Karina Zamel, Victoria Jupp, and Grayson Beaubien. AV production was led by Kevin Young. Be sure to visit us at bakerinstitute.org to learn more. Thank you for listening.